Methamphetamine.
This is what I do to motivate myself a little bit.
A drug that was also known for a while as redneck cocaine. They use it, but so do gay men in urban centers.
A lot of people use it for sex.
As a way of sort of enhancing their lives, enhancing their partying.
But no, I do it and I channel my inner passions.
Over 11 million Americans have tried meth at least once. The same data says 440,000 were last month users, according to DEA meth seizure data.
In this video, I want to explain why meth can make someone seem like a completely different person. Not just more energetic, not just more impulsive, but different, more suspicious, more repetitive, more sexually driven, more emotionally volatile, more disconnected from the people and values that once mattered to them. I've done a lot of videos on methamphetamine and its impact on the brain and behavior. And the comment section has taught me a lot. Comments such as, I could never imagine doing the things I did on meth if I was sober. Another comment summarized this really well. Methamphetamine is really deceptive because it makes you believe that it's good for you. The easy explanation and the commonly found one on social media is that meth hijacks dopamine. That's partly true, but it's incomplete. Meth does not simply create pleasure. It changes what feels important. It changes what's known as salience. It makes certain cues feel urgent, almost magnetic, and impossible to ignore. Even the most trivial of aspects, such as an itch, can move towards severe skin picking. At the same time, it weakens the frontal-lobe systems that help us pause, inhibit, reflect, and think about consequences. So with meth, the person's not just chasing a high. They're not just wanting pleasure. The brain is being pushed into a narrower and narrower world, where the drug, the cue, the craving, the sexual urge, the paranoia, or the relief from it, and the repetitive behavior becomes the center of gravity. I'm Dr. Sanil Rege, consultant psychiatrist and educator. I've trained over 10,000 professionals in psychiatry and psychopharmacology. And in clinical practice, I know that methamphetamine addiction is one of the most challenging addictions to treat. So in this video, I want to explain methamphetamine addiction in a way that's scientific, but also human. Because we want to go beyond just the behavior. We want to understand the mechanism, what shapes this individual. A quick disclaimer, this is an educational video and is not meant to be taken as personalized medical advice. First, meth changes what the brain treats as important. Dopamine is partly involved in pleasure, but its function is more about motivation, salience, what the brain tags as important, prediction, effort, and learning. It helps the brain decide what matters right now. What should I move towards? What should I ignore? What is worth repeating? Dopamine constitutes 80% of the catecholamine content in the brain. It's a highly conserved neurotransmitter. But beyond dopamine, we also have noradrenaline and serotonin. What meth does is it results in significant release of dopamine, noradrenaline, and serotonin. It's a dramatic amplification of drive. And what happens here is that cues can become magnified. So a sexual cue can feel irresistible. A small threat can feel certain. Minor irritation can feel magnified. A repetitive task can become compulsive. A mirror or a scab or a phone, a message, a grievance, any of these can become magnets. The brain's saying, this matters. And once something is coded as important, the person can be pulled towards it again and again. This is a key reason why meth use can change someone so quickly. It reorganizes the hierarchy of importance inside the brain. The ordinary world becomes dull. And this leads to meth anhedonia, covered in this video here. The meth-linked world becomes important and urgent. And that's where the narrowing begins. The second mechanism is about the balance between the accelerator and the brake. You see, in ordinary life, we do not act on every impulse. We pause, we inhibit, we reflect. We ask, should I? That pause is one of the important functions of the frontal lobe. The prefrontal cortex helps us with planning, sequencing, judgment, decision-making, risk-benefit analysis, impulse control, emotional control, and future-based thinking. Methamphetamine places that system under immense pressure. It increases the drive from below, from the limbic pathways, whilst at the same time weakening the control from above. So if you think of an analogy, it's someone driving a car that has their foot completely off the brake and is stepping on the accelerator to the maximum degree. The problem is not that the accelerator is pressed, the brake's compromised. This is why someone may know exactly what meth is doing to their life, but still return to it. They can see the relationship collapsing. They know their sleep's affected. They know the paranoia is worsening. They know their body is deteriorating. But we know that knowledge is not the same as control. Humans are bundles of habits. And once habits are consolidated deep, they repeat. And this is one of the most painful parts of addiction. This is exactly what makes addiction, particularly methamphetamine addiction, so difficult to treat. A person may describe the problem clearly when they're reflective. I see this every day in clinical practice. Patients know what's happening, what they want, what they should do. But in the moment of emotional heightening, with shame, loneliness, sexual arousal, withdrawal, cue exposure, the reflective brain can be overwhelmed. The frontal lobe shuts down. The future becomes abstract. The immediate state becomes everything. The relief from pain is where the pleasure lies. So when people say, why don't they just think of the consequences? Often they have. But the immediate issue is the relief of the discomfort. And the brain has a solution, meth use. And that's the reason why it automatically moves towards the substance. Meth has changed the balance between importance, impulse, habit, and inhibition. Number 3, the world starts to narrow. One of the most important concepts in addiction is narrowing. It's known as narrowing of repertoire. A healthy nervous system and brain has a broad repertoire. So, for example, when distressed, a person might pick up the phone and speak to someone, or sleep, exercise, reflect, cry, seek help, wait, pray, write, may engage in therapy, or simply use emotional regulation strategies to tolerate the feeling until it passes. Addiction narrows the repertoire. More and more emotional states begin to have one answer, one solution: use. Use again. Find more. Recover. Use again. This is not unique to meth. We see the same principle with alcohol, gambling, food, sex, pornography, compulsive scrolling, and other addictions. These behaviors are not random. These are objects of emotional regulation because they're reliable, controllable, and predictable, always available when people aren't. I've seen this in clinical practice when I've asked individuals what the substances do for them. And a common answer is they're predictable. I know exactly what I'll get from them. The same individual is uncertain about what the world and other people around them provide. And this is where the psychodynamic layer becomes important. Because addictive behaviors are not only about pleasure. In fact, chronic addiction often isn't about pleasure. It's about removing the pain. These substances regulate a feeling. For one person, meth creates confidence where there was shame. For another, it creates energy where there was fatigue. For another, sexual intensity where there was emptiness. This video I did on meth and sex, the comment section has really taught me a lot about how powerful the association is between methamphetamine and sex. For another individual, control where there was helplessness. And we see this in clinical practice. Individuals saying, it makes me feel normal. It takes away the pain. I can trust what it does. These are not pharmacological mechanisms, but they're amongst the most powerful descriptions of drug effects. They're clues to the emotional function of the drug. The brain has learned, when I feel unbearable, this changes the state. And when something reliably changes an internal state, the brain remembers. Eventually, it just stops asking questions because it's found a solution. It just repeats. The fourth step in changing the person is when the individual moves from goal-directed action, a choice of voluntary action, towards becoming automatized. Early in addiction, the person may be chasing the high, the energy, the confidence, the sexual enhancement, the relief, the escape. But over time, addiction can shift from reward-driven behavior, goal-directed actions, choices, to habit-driven behavior. This is sometimes described as the ventral to dorsal striatal shift. In simple terms, the behavior moves from I want this to I'm doing this without knowing why. The person may not even enjoy it anymore. They often say, I know it's not fun now. I hate what it's doing to me. I don't know why I keep going back. This is the shift from reward to compulsion, from impulsivity to compulsivity, from pleasure to relief, from choice to automaticity. And this is why addiction can look so confusing from the outside, because other people say, why would someone keep doing something that is destroying them? We can answer this question with empathy when we understand that humans are bundles of habits. 95% of our goal-directed actions are automatic. That's how we function, because the brain has to conserve energy by converting our goal-directed actions into automatized behaviors. What often happens involuntarily is that the cue appears, could be the person seeing a pipe. The body changes, the craving rises, the mind searches for permission, the behavior begins. Much of this is automatic. Then afterwards, the reflective self returns and says, why did I do that again? The person's not making an excuse. It's a neurobiological mechanism. If we understand the mechanism, we can then shape the appropriate treatment for the individual. Here you might say, well, why would the brain repeat something that is harming it? This is where we understand the prediction loop in a bit more detail. You see, the brain is a predictive organ. Its aim isn't to make you happy. Its aim is to make the world around you predictable. I've covered this concept in the video here. So the brain's constantly making predictions, and it's trying to match prediction with outcome. If I do this, what will I feel? If I reach out, will someone respond? If I show vulnerability, what would I receive? If I wait, will the distress pass? You can see it's constantly trying to reach a solution. The prediction and outcome match. In addiction, the brain learns a powerful prediction. The prediction is this: there's an unmet need which is associated with emotional arousal. Any unmet need is associated with arousal. The addictive act, taking of the substance, results in relief. And relief is a very powerful teacher. The brain learns that worked. It's not bothered about whether it comes with a cost, whether it's safe or not. In that moment, the brain's learned this worked. That's how the loop becomes reinforced, because when emotional pain arises because of any range of circumstances, meth use is predictable, and meth use is associated with relief. Prediction confirmed. Repeat. Over time, the loop becomes automatic. The nervous system no longer needs a complex explanation. It simply learns at a deeper level, when I feel this, I do that. With long-term use of meth starts becoming part of the individual's identity. Meth is particularly powerful because it can create a version of the self that feels compelling, confident, fearless, sexual, energetic, social, dominant, productive. For someone who's lived with shame or depression or trauma, pain, rejection, loneliness, that state can feel seductive. So for the individual, it's not I like the drug. It becomes I like who I am on the drug. And that is a deeper trap, because meth now has fused with the person's identity. The person starts believing, this is the real me. This is the only time I can connect. This is the only time I can perform. This is the only time I feel alive. But the drug-created self comes at a cost. Besides sleep and diet collapsing, trust collapses, relationships collapse. The frontal lobe weakens and the behavioral repertoire narrows. The person's world narrows. Life now becomes organized around obtaining, using, hiding, explaining, repairing, and repeating. And people around the person say, they changed. And they did. What actually happened was that the brain's priorities were reorganized. The self became organized around the drug. Whilst meth use can fuse with identity, in some individuals, meth use can produce psychotic symptoms and distort reality. Not in everyone, but in some, It can lead to suspiciousness, paranoia, hallucinations, and fixed, firm, false beliefs that we call delusions. This happens because meth destabilizes salience. The brain begins assigning meaning to noise, multiple stimuli, so a glance becomes evidence of persecution. A coincidence becomes a pattern. A message can become a threat. That television can change into surveillance. And because meth also increases arousal and reduces sleep, the brain becomes even more vulnerable. This results in a state known as aberrant salience. The brain's threat sensitive. It's trying to make sense of an overstimulated internal world. And this is why meth-related paranoia can escalate quickly. And it's not something to be taken lightly. It may require urgent clinical assessment, risk management, and treatment. You can view a video on meth psychosis here. So now that we understand the mechanisms that can change the person, let's think, what can we use to help the individual? When it comes to addiction recovery, recovery has several layers. The first step is safety and stabilization. Sleep, nutrition, medical care, psychiatric assessment, and risk management are important. Meth can result in depression, psychosis, aggression, cognitive impairment, and serious physical complications. These need proper attention. Second, structure. The brain needs rhythm, regular sleep-wake timing, reduced cue exposure, supportive routines, contingency management where available, and practical relapse prevention. Third, relationships. This is crucial. Connection matters because attachment is the original regulator. But in many people with addiction, they've been hurt in relationships. They have early life trauma. Therefore, these connections have to be built carefully because trust is shaky. Fourth, pharmacology, both to address the addiction, but also any additional psychiatric comorbidities. There's no simple magic medication for meth addiction. The medication can still matter. Treating comorbid depression, ADHD, trauma symptoms, psychosis, anxiety, and sleep disorders can reduce that internal heightened state that drives relapse. We should also pay attention to the stress and anti-reward systems, addressing dynorphin, kappa opioid receptor system, which are involved in dysphoria, emotional pain, and avoidance. Here, evidence-based agents such as naltrexone or bupropion, mirtazapine, lisdexamfetamine, all are evidence-based in the treatment of methamphetamine misuse and dependence. But they have to be introduced carefully and cautiously. Fifth, and a crucial aspect of the psychodynamic exploration. It's important for us to understand the emotional world of the individual, the emotional world driving the habit. What emotional experience is being avoided? What need went unmet? What relational pattern is being replayed? What version of the self did meth create? Therapy helps convert the compulsion into language. And when something can be named, we can start to work with it. So there's one thing to take away from this video, it's this. Meth can change people dramatically. Not because it creates a high, but because it reorganizes the fundamental structure of the brain. It reorganizes salience, what matters. It weakens frontal control. It shifts behavior from choice to habit. It narrows the person's repertoire. It turns relief into a predictable solution. It attaches itself to shame, loneliness, sexuality, confidence, trauma, identity, and emotional pain. And over time, it begins to function like a false regulator, a predictable object, a chemical answer to an emotional question. So recovery is the slow work of helping the brain learn something new. There are other ways to feel safe, to feel alive, to feel connected. I'm Dr. Sanil Rege, and you're watching the Dr. Rege channel. If this kind of psychiatry interests you, neuroscience, psychodynamics, addiction, clinical practice all brought together, hit the like button and subscribe to our channel. And for clinicians who want deeper structured learning, explore the Academy by PsychScene. I look forward to seeing you in the next video. Until then, stay curious. Bye-bye.